Hello guys and welcome to my channel. Today we are going to have a discussion on the topic of first pass metabolism. And we will be discussing our topics under these headings. So let us take one heading at a time. Let us first understand what the word first pass metabolism means. First pass metabolism is the reduction in the concentration of the active drug at its site of action or the systemic circulation due to its metabolism at any other specific location. That is, let us suppose we are taking a oral drug, right? And we want this drug to act in the brain. But for this drug to reach the brain, it must be first absorbed into the systemic circulation. So from systemic circulation, the drug will reach the brain. So prior to the drug being absorbed into the systemic circulation, if there is metabolism of the drug, then the amount of drug that will ultimately reach this systemic circulation will be low. Now why will it be low? Because if you remember the pharmacokinetics, then we all know that pharmacokinetics basically has four properties, right? Which is A, D, M, E. A for absorption, D for distribution, M for metabolism and E for elimination. So after metabolism, a drug is supposed to be eliminated. So in most of the cases, once there is metabolism of the drug, then the drug will be ultimately converted to a water soluble compound, so that this compound can ultimately be eliminated by the kidneys. So if there is metabolism of the drug prior to being absorbed into the systemic circulation, then obviously you can understand that the amount of active drug that will ultimately reach the systemic circulation will be low. It is also known as a pre-systemic metabolism. Why pre-systemic? Because it is occurring before the drug has been absorbed into the systemic circulation. Let us now have an overview of first pass metabolism. So for a drug that is given orally, it will first reach to the lumen of the gut. Then from the lumen of the gut, it will cross the gut wall and reach the hepatic portal vein. From the hepatic portal vein, it will reach the liver, and from the liver ultimately to the systemic circulation. So during the journey of the drug from the lumen of the gut to the systemic circulation, there can be three places where the drug can undergo first pass metabolism. The first one is when the drug will cross the gut wall to be absorbed into the hepatic portal vein. Now this will occur due to the presence of the enzyme CYP3A4. The second one is when the drug is there in the hepatic portal vein, and the third is in the liver. Now the liver is the most common site for the first pass metabolism to occur. Now in my earlier video on bioavailability, I have already talked about why will a drug preferably be absorbed from the lumen of the gut. The description is there in the description box. Please check out that video. Let us now have a look at the sites for the first pass metabolism. As I have already told you that the liver is the most common site of first pass metabolism. Other than liver, the first pass metabolism can also occur in lungs, the portal blood, as well as the gut wall. In the gut wall, due to the presence of the enzyme cytochrome 3A4, first pass metabolism of a drug can occur. So now let us come to what do we mean by the word hepatic extraction ratio. So hepatic extraction ratio means the fraction of the absorbed drug which is prevented by the liver from reaching the systemic circulation. So as you can see from the name, hepatic extraction. So who is extracting the drug? Obviously the liver is extracting the drug. So it is the liver that is ultimately preventing the drug from reaching the systemic circulation. and the fraction of that drug is the hepatic extraction ratio. So it is determined by the equation the clearance of the drug in the liver divided by the hepatic blood flow. The clearance of the drug is signified by Cl and the hepatic blood flow by Q. So more the clearance, since the hepatic extraction ratio is directly proportional to clearance, so since we can see that the extraction ratio, since it is directly proportional to clearance, so more the clearance, more will be the extraction ratio, and more the extraction ratio, less will be the drug that will ultimately reach the systemic circulation. Now vice versa, extraction ratio, it is inversely proportional to the hepatic blood flow. That means more the hepatic blood flow, lesser will be the extraction ratio, and consequently more will be the drug that will ultimately reach the systemic circulation. So moving on, what are the effect of hepatic extraction ratio on bioavailability? Now there is a detailed lecture on bioavailability. The link for that video will be given in the description box. Please do check it out. So the bioavailability of an orally administered drug can be derived from basically two factors. The first one is the extent of absorption and second one is the extraction ratio. So we are signifying extent of absorption with small f, extraction ratio with ER, and bioavailability with capital F. So the formula that we are ultimately going to get is that the bioavailability is equal to the extent of absorption or the small f multiplied by 1 minus the extraction ratio. Let us now calculate bioavailability from the formula that we have learned. Let us take the example of morphine, which is an opioid analgesic. Since morphine is completely absorbed, so the extent of absorption will be 1. The hepatic clearance for morphine for a 70 kg human is 60 liter per hour. The hepatic blood flow for a 70 kg human is 90 liter per hour. So we know the extraction ratio is clearance divided by the hepatic blood flow. So if we substitute the values, we are going to get the extraction ratio to be 0.67. So the bioavailability from the formula that we have learned just now is extent of absorption into 1 minus extraction ratio. So substituting all the values, we are going to get the result to be 0.33. If we express this in percentage, then we are going to get the result as 33%. The actual oral bioavailability of morphine is about 24%. So as we are seeing, the value that we have calculated very closely resembles the value of oral bioavailability of morphine. So now some drugs which have got high and low first pass metabolism. So drugs with high first pass metabolism are lignocaine, hydrocortisone, testosterone, propanolol, salbutamol and glyceryl trinitrate. And the drugs which have got low first pass metabolism are theophylline, diazepam, pindolol and isosorbate mononitrate. So naturally for the drugs that have got high first pass metabolism, if they are given orally, then we are going to need a larger dose for it to achieve the therapeutic concentration, because remember, more the first pass metabolism, lesser is the amount of drug that is reaching the systemic circulation. So in that case, suppose we are taking the example of lignocaine. So obviously the oral dose of lignocaine will be high. Again, since it has got high first pass metabolism, so the lignocaine will be converted into its metabolites. The lignocaine will be converted into its metabolites due to the first pass metabolism. Now the problem with these metabolites is that these metabolites of lignocaine, they can cause CNS toxicity. Hence, lignocaine is not given orally. In fact, lignocaine, hydrocortisone and testosterone, these three drugs, they are not given orally. So what are the characteristics of drugs with high fast metabolism? So as we have already discussed, that the first point will be that oral dose will be much higher than the parenteral or the sublingual dose, right? Because again, as I have already told, that the oral dose needs to be higher so that the amount of active drug that will ultimately reach the systemic circulation, that level is high so that we can achieve the therapeutic concentration of the drug. So in order to achieve the therapeutic concentration of the drug, we have to increase the oral dose. Second point is that there will be marked individual variation in oral dose due to different extent of first pass metabolism. Now you have to also understand that this extent of first pass metabolism varies from person to person. There will be a number of factors that will ultimately determine the extent of first pass metabolism. So since the first pass metabolism extent is different for different persons, naturally the oral dose will be different based on that first pass metabolism. And third point is that for patients with severe liver disease, oral bioavailability is increased. Now you can understand it very clearly. If the patient has got liver disease, and we all have studied that the most common site of first pass metabolism is the liver. The most common site is the liver. Hence, if the patient has a liver disease and the function of the liver in itself is compromised, then naturally the amount of drug that is going to reach into the systemic circulation, that will be high. So if the amount of drug that is reaching the systemic circulation becomes very high because of severe compromise of the liver, then naturally the chances of toxicity is also going to increase. In medical science, we have to always balance a very important concept, that is the risk is to the benefit ratio. We always want the patient to have more benefit and less risks. So remember, the benefit should always outweigh risk. Let us now see the routes of administration of a drug that will ultimately help it to bypass the first pass metabolism. One route that we all know is the intravenous route. So if a drug is given by the intravenous route, it is directly given into the systemic circulation itself. Hence naturally the first pass metabolism will be bypassed. Other than the intravenous route, you have the sublingual route, the transdermal route and the rectal suppositories. But for the rectal suppositories, a lesser extent of the drug, or rather a lesser amount of the drug, is actually able to bypass this first pass metabolism. Let us see it in a bit detail. For the sublingual route as well as the transdermal preparations, from here the drug is directly absorbed into the systemic circulation and not into the local circulation. Please remember this point. That is, from the sublingual as well as from the transdermal preparation, the drug directly goes into the systemic circulation and not the local circulation. For the rectal suppositories, see what happens. Suppose this is the rectum. So if we give a rectal suppository, the tendency of the rectal suppository is to go upwards. So now in the lower part of the rectum, when the drug is in the lower part of the rectum, from there it is directly absorbed by the inferior vena cava. Hence it directly reaches the systemic circulation. So obviously the liver is bypassed. and so is the first pass metabolism. But as it goes up, when it reaches the upper part, from there through the rectal veins, it is actually drained to the portal vein. And once it reaches the portal vein, from there it will go into the liver. So in reality, actually 50% of the given dose of a drug, which is given as a rectal suppository, is actually able to bypass this first pass metabolism. So thank you very much. If you like this video, please share it, give it a thumbs up and subscribe to my channel. And please write down in the comments below what is the next topic that you would like to discuss. Until next time.